My pleasure to introduce today's Grand Round speaker, Dr. Suliman El-Amin, who is a graduate of Georgetown University School of Medicine in Washington, D.C. Prior to attending medical school, Dr. El-Amin earned bachelor's and master's degrees in biology from Morehouse College in Atlanta and the University of St. Joseph in West Hartford, respectively. He then went to Minnesota, where he completed his adult psychiatry residency and child and adolescent psychiatry fellowship at the Mayo Clinic in Rochester, Minnesota. Currently, Dr. El-Amin is the chief of psychiatry at UMass Memorial Marlborough Hospital and is an assistant professor of psychiatry at the UMass T.H. Chan School of Medicine. His research interests include medical humanities, bipolar disorder, and health disparities in psychiatry. Outside of clinical practice, Dr. El-Amin is a visual artist with works featured as cover art for several medical journals, in national publications, and showcased in museums around the country. The title of his talk today is A Candle in the Dark, Preventing Suicide in Black Youth. Let's give a warm welcome for Dr. El-Amin.
Thank you so much, and thank you for inviting me here. It's actually really good to see all of you in person, and I'm just saying hi to my virtual friends. That bio was way cooler from hearing it from you, so thank you for those kind words. As you mentioned, I will be talking about a very serious topic, preventing suicide in Black youth. So I will be presenting some numbers and some data. This is a topic that's near and dear to my heart, not only because I am a Black man, but one of my interests, as my colleague just said, was mood disorders. And then another interest is health disparities. But that third interest, medical humanities and art, is near and dear to my heart. I am a visual artist, so while I'll present numbers, I wanted to make things a little bit more lively for everyone. So I will have some art pieces in there. And also I will present a small or a very brief case presentation. So I do not have any disclosures. And I do want to talk about a few things. So I do want to look at the national and local trends in suicide rates, specifically for Black youth. We will then take a closer look at risk and protective factors with this population. Oh, sorry. And I'll speak loud. It's kind of hard for me to down. And thank you. And then finally, we will discuss strategies in suicide prevention, specifically for this population. And as I stated before, in between the data, I will try to illustrate what the data is trying to present. So, can I ask a fun question for the audience? This is a picture that I drew probably a year out of training. I was a child and adolescent psychiatrist in a wonderful outpatient clinic in central Pennsylvania. And my take on it was, I'm working really long hours, love the work I do, but am I making time for play? Am I forgetting my childlike self? That's what I got from this picture. I want to ask, do y'all see anything else in this picture? Any thoughts with it? And there's no right or wrong answer, of course. I love it. Yes, definitely. Any other comments on it? Again, no right or wrong answer. So let me tell why I put this picture up. So, I show my artwork off, and I was showing a colleague who happens to be a Black woman this picture. And she said something that was interesting to me, and it just had me think. She said, maybe the bear that looks a little bit more realistic is wondering why he's not taken the same as the bear who's the plush teddy bear. Maybe he wants to be cuddly and warm and kind and not scary. And I was like, wow, I totally didn't get that, but it gave me insight to perhaps her own struggles. So as I present this data, kind of try to take things from a different perspective. Feel free to ask questions because I'm still grappling with some of what I learned by putting this presentation together. So some general data. So youth and young adult suicide accounts for about 14% of suicides in this country. It is the third leading cause of death in youth and young persons ages 15 to 24, and the second leading cause in adolescents. And the most at risk are American Indians, Alaska Natives, and sexual minorities. And similar to adult data, suicide attempts are more reported in girls. So this is CDC data, and this includes adult data. So this is not particularly youth. So this is suicide death rates by race and ethnicity from 2010 to 2020. And just an easy scan on this, you can see that the numbers increase for all races. But just looking at those minority persons, you see the numbers have increased more significantly, and with Black individuals leading, and then right under that is American Indians and Alaska Natives. So now let's just take a look at high schoolers. And this data comes from the CDC's Youth Risk Behavior Survey data, which provides surveillance information on behaviors and experience of high school students, and is collected every 2 years. So if we just pay attention to that orange line, which represents Black high schoolers, you can see from the time period from 2011 to 2021, that number almost doubled. So rightfully so, this trend or this trend of suicide death rates rising among Black youth made national news. And I think it was appropriate, but it led to a lot of additional research, what I'll get into. But let's look at some local data, some Massachusetts data, to see if it matches our national data. So this graph is from data from the Massachusetts Department of Education, who in collaboration with the CDC conducts their own youth behavior survey and randomly selected public high schools every 2 years. The data focuses on major risk factors that threaten children's health. So as you can see here, just focusing on that data, we can see that youth who identify as Black reported considering suicide at higher rates than any other race. And interestingly, this is 2019 data. And as I stated, this data is collected every 2 years. So 2021 data was supposed to be out in January, but there's been a delay. So, these are some of the, so this graph shows that youth who identify as Hispanic, Black, and Asian reported attempted suicide at a much higher rate than white youth. And this is some of the questions that were on that survey. So it's about questions about multiple things that affect children's health risk, but there's 6 questions particular to suicide. And it covers a 12-month span. So recently, researchers at Nationwide Children's Hospital in Columbus specifically looked at trends in Black youth suicide using 2 CDC national databases. The goal of this study was to determine if there was a difference in suicide rates and factors that led to a suicide attempt across gender and age in this population. So some key findings of this study. So Black youth suicide deaths were mostly in boys and between the ages of 15 and 17. And for Black youths, they mostly died by hanging, strangulation, suffocation, and in their own residence. And interestingly, Black girls between that age of 12 and 14 had a higher proportion of suicide deaths compared to girls in other age groups. So So just taking a closer look at this data, and this is data looking at suicide death rates in all Black children ranging from 5 to 17. And that top graph represents 5 to 11-year-olds. That middle graph represents 12 to 14-year-olds. And that graph at the bottom is our 15 to 17-year-olds. And you can easily see with all 3 graphs, there's been an uptrend in suicide deaths. during this time period. But the greatest change has been in that older group. So this graph looks particularly at boys and girls. Girls are on the bottom here, boys are on the top. As you can see, there's been an increase in both boys and girls during this time frame, but there's a higher percent increase among Black girls, and it's almost twice as much as Black boys. So when they looked at factors that led to suicide, they found with the older children, there was usually relationship challenges and recent legal problems that led to suicide death. With the younger children, suicide death was preceded by family and school problems. And interestingly, with this cohort, about 35% of them did have a current mental health problem prior to their passing. With the older children, that mental health disorder was depression. Excuse me. But with those younger children, that 5 to 11-year-old group, they were diagnosed with ADHD as the most common diagnosis and not depression. Interestingly, a subsequent study which compared age-specific suicide rates between Black and white children showed that these elementary age Black children were 2 times more likely to die from suicide compared to white children. And for those older teens, another study showed that this group had a higher rate of suicide attempts without reporting. So Black children are disproportionately affected by adverse child experience, so abuse, neglect, violence, discrimination, etc. They also face more socioeconomic disadvantages. They're more likely to live in poverty, have public insurance, or are uninsured. However, they receive far less mental health services compared to other races. And just going more into risk factors, when they do receive care, there is concern for clinician bias or parent underreporting due to mental health stigma. And for me, this means that there's a missed opportunity to prevent a suicide or even a diagnosis such as depression. In a recent study, researchers looked at data from the National Survey of Children's Health, which included statistics on a large sample of Black and white school-aged children. The data set included reports of diagnosed mental health disorders and parent-reported characteristics. The researchers found that for Black children, they were far less likely to be diagnosed with internalizing conditions such as anxiety and depression. Furthermore, these children were diagnosed with conduct problems despite there being no significant difference in reported ADHD symptoms. So I want to pause there because I know I mentioned a bunch of data points there, but I want to ask the audience, what's your thoughts with that last piece of data? So I'll repeat. So for our younger children, they're being diagnosed with ADHD, but we're missing the mood disorder component here. They're less likely to be diagnosed with an internalizing disorder such as anxiety and depression. I got stuck on this data just because I showed earlier that upward trend in suicide death rates in that age group. My thoughts were, with the diagnosis of ADHD, we got to think about how problems in school and with family affect the kid. And with that diagnosis of ADHD, it should, on the other hand, have an assessment for suicide. So when considering the factors that put a person at risk for suicide, the concept of self-worth has to be a part of the discussion, as studies have already shown that Black youth are disproportionately affected by adverse child experiences, socioeconomic challenges. Therefore, it would be reasonable to think that Black children may believe their lives are less meaningful than others. A recent study did seek to determine if feelings of worthlessness and parental relationships are associated with suicidal ideation, planning, and attempts, and a small sample size of Black children. The idea was that if feelings of worthlessness were associated with suicide, then a positive support in the form of verbal affirmation and less parental conflict will correlate to a decrease in suicidal thinking. And so their findings did show that feelings of worthlessness was associated with a greater desires of suicidality in both boys and girls. In addition, parental conflict increased suicidal thinking, planning, and attempts in children, in girls, but only ideation in boys. And then receiving verbal affirmation from parents was only helpful in reducing suicidal thinking in girls. So I talked about risk factors. There are some protective factors, albeit the research is less robust. So research on protective factors is limited. However, a recent systemic review, which looked at 26 articles, identified the most strongly supported factors that protect a child from suicide include familial, relational, and social and personal factors, followed by, and to a lesser extent, religiosity-based and social ecological factors. So to add some texture, having a sense of belonging and feeling connected to supports and having accessibility to family members you trust does help a child be less suicidal. And pointing up to the religious factor in it, it wasn't so much having a structured religion, but having the feeling that your life is meaningful on a deeper level. So another study looked at protective factors against suicide in Black youth. So the study looked at data from youth who had arrest records and noted to have higher levels. It noted that they had higher levels of positive parenting, and school engagement was associated with lower levels of suicidal ideation and planning and attempts. So I presented a lot of data, and there's still more coming out each day. But rightfully so, there's been a robust response by organized medicine and the federal government to figure out why we're having this uptrend in suicide in Black youth. I wanted to focus on a few of those statements. So the American Academy of Child and Adolescent Psychiatry made several recommendations, including calling on more research and advocacy work in this area. They also recommended that a psychiatrist collaborate with other systems of care involved in lives in Black youth outside of the health system. And they also recommended strongly to improve identification of suicidal thoughts and improving access to care and retention. Lastly, there was a call to support evidence-based resiliency programs that focus on protective factors. The APA had a similar statement calling for more research on the subject matter and suggesting that there be a way that we implement effective interventions to address this issue. So now for the fun part, what can we do? You know, these are statements that were made, and I got a few suggestions myself, but you guys are hearing the data. I just want to know if there's any thoughts of what can you do as a provider to help be a candle in the dark in someone's darkest moment.
It seems strange that although we know that there's high risk factors for Black youth, and yet we underdiagnose or, whether they're less frequently diagnosed with major depressive disorder and receiving mental health treatment. I wonder, we know that in pain for minorities, pain tends to be not as readily believed or treated in the hospital or in other settings as they are for white people. So I wonder if maybe there's like a bias from providers against maybe hearing the same symptoms having similar PHQ 9 scores or GAT-7 scores, and yet not thinking that it rises to the level where it needs treatment. So I think even just looking into that bias, seeing if there's a correlation between and a difference between minorities versus whites and how readily we are to treat or offer mental health treatment.
I love it. So I appreciate that, Bagi. Can I make a comment? So why am I so interested in mood disorders? So when I was a resident, I still struggle with this patient. Like I saw the patient in an emergency department, and you could not tell me they were psychotic and they had schizophrenia. Like I knew it second year. And this patient ultimately got admitted to our unit. Turns out he had bipolar disorder. And he needed a mood stabilizing agent, got well, got better, Black man. And I struggled with that. And part of it is, of course, I don't like to get things wrong, but I found out I wasn't the only one making this mistake. There were Black providers making this mistake, minority providers making this mistake. And we all were just struggling with what does bipolar disorder look like in an African American population. So with this data, I do wonder, what does suicidal ideation looks like for a young Black child? What is it that we're not hearing? And so that's what I went back to that picture, because that picture that I put up there, I thought for certain, hey, this is about a tired bear who wants to connect with his childhood. But when I give it to another person, they say, no, this is my life. And so I really struggle, and this is where research will come into play. Like, how are we looking at these patients? Are their symptom presentation just stated in a different way that we're not catching? I get that you send a kid here for ADHD, he's struggling in school, his grades are poor, you may have all the symptoms, but I'm not blinded by that and missing the mood disorder symptoms under that. That's my struggle with the data. So great point you mentioned. So just going back, there are some things we can do, and this is right on target. Although there's no screening questions developed specifically for Black youth, it is important to routinely ask Black youth about suicide and self-injurious behavior. Recent findings suggest that parents of Black youth are more likely to be unaware of suicidal thoughts in their child. In addition, Black youth are more likely to deny suicidal thinking to their parents. And for providers, it's also equally important to be aware that the exposure to racism, discrimination, community violence, and trauma occur disproportionately to Black youth and can serve as risk factors for suicide. Now, for mental health utilization, there are things that increase barriers, but there's also facilitators. The most relevant barriers that keep Black youth away from utilizing mental health are the perceived self-reliance, mental health stigma, mistrust of providers, and their perception of treatment effectiveness. But just like their barriers, as I said, they're facilitators. So the more severe mental illness, the likely they are to utilize mental health care. If they have a supporting social network that helps. If parents' expectations and experience with mental health services is good, the kid will usually have utilization of those services. And family, a good referral source for someone they trust, a family member, usually helps. Now to intervention. So as I alluded to, there's limited empirical data on which interventions work well in this population. There aren't a number of large-scale trials with Black youth at this point. So we as providers need to identify alternative settings and ways to deliver services to Black youth. We have to think about providing services in a community setting and partnering with the communities to explore those alternatives. So I actually want to get into a case, and I always tell the residents, we live now. This is happening, and we got to figure this out. I'm a community psychiatrist, so what comes in the door, we deal with right there. And so I think it's been a week now. I had, and I changed a few things up here, of course, a 17-year-old African-American female who was adopted to Irish parents. She came to my ED. She had a history of major depression, major suicidal ideation. She did have a 3-month history of escalated suicidal thoughts. Recent cannabis use, this was causing a lot of friction. She was getting high in school. Parents, of course, did not want her to use marijuana. And they had actually made her have her enroll in a PHP program. She was in it for 3 weeks. So out of school and actually in this program. And now the kid was being told, okay, the program is over. You got to go to school on Monday. The huge problem was mom was so livid about the marijuana use. She actually told the school principal. He did a full raid of a bunch of students there. So this kid was really concerned about coming back to high school because she was fearful of retaliation, being bullied, etc. And so here I am, and she boarded for about 3 days. And I probably spent about 3 hours with her. So maybe an hour each day, and then some time with mom. So I would periodically drop in and talk to mom when she was there. But in our conversations, I got to learn about this kid. I didn't assume I knew who this kid was. Her culture was slightly different from mine. So she was an African-American girl, but I never, I'm not adopted. I'm not adopted to Irish parents. I didn't grow up in Marlboro. I'm not from that generation. So I don't assume I know everything, but man, am I curious. I like to listen. I like questions, and I got questions. Like, it's a genuine interest because I'm just curious. And so she talked about her life. She talked about some of her friends and some of her friends making racist jokes and how she had to get over that quickly, and that she had a limited group of friends, and that's why she was so frustrated. She also talked about, I know my biological parents, and they had substance use problems. Now here I am using it. It's become such a big deal, and she was somewhat ambivalent about stopping marijuana. And then separately, her mom, who's Irish descent, was like, does this kid really love me? I adopted her as a toddler. I can't believe we're going through this. This is the big issue. So it was so many issues right there. But through our conversation, we did some safety planning. So I meet the kids and we start talking about safety from day one. So we talk about your life, and I'm like, how can we support you to be safe? What do we need to do? Like, how can we help you? It is scary going back to school. That scares me. How do you feel? And so I learned a little bit about our life, and I don't say I had perfect answers with this. And these are some of the questions I posed, but I think I answered some of them. So are there cultural impacts that need to be explored? You know, I talked about, what her community looks like for her. She did have some exposure to racism. And then I was like, what are some positive organizations in her community that could provide ongoing support? To be honest, I didn't know. I'll just be honest, I did not know. And that's okay, because I did ask for help. And I got help. So as I stated, I understood her perspective, where she was coming from. An interesting thing I do with children, if I see any kids in blue scrubs, I come and say hi to them. Even if I'm not seeing them, I need therapeutic rapport immediately. So anytime I'm in the ED, I might joke with them in a good place, laugh, ask them cheesy questions, because I know eventually I'm going to talk with them, and I need them to trust me quickly. So that's one of the main things I did. I think that's why we have rapport pretty quickly. And again, I didn't have perfect answers, but for some reason, she was able to work with her mom, work with us, and we developed a beautiful safety plan. And her suicidality resolved, and she was able to go home. But because we had this great connection, of course, mom, like, can I see you in an outpatient? Like, and I'm like, no, I'm sorry. And I know that sounds horrible, but to be honest, I have to be a good physician, and could I dedicate the time to that kid that they needed? And I know I couldn't with my workload in the inpatient room. But I said, I'll help you find a therapist. And this is where I asked, phone a friend. So I said, what, I know a couple of African Americans in this community, and I asked, is there some sort of resource? Because I don't know. And they mentioned that there's a website called Black Girl Therapy. I think that's what it's called. So I actually introduced that concept to them in the in the hospital. And I said, how about you and mine work together and y'all pick out a therapist together, and then you see if that person has an appointment. Now, I do know therapy appointment takes weeks to sometimes months. I needed something in the interim. So another thought was like, wow, this kid is interested in going to college. Does she know about historically Black colleges and universities? Does she know about historically Black colleges that have sororities that are into mental health? And this is what I'm talking about, thinking about this a little bit different. So I connected mom to some of these organizations and said, you need to have this kid about positive role models who can help identify suicidal thoughts. And then I suggested, hey, mom, when the dust settles in this, probably take her to visit some of these colleges, give her something to shoot for. And so this goes to the point, and I don't say I'm perfect in this, but trying to create a community around children. And so I love this image. So we all have heard of the saying that it takes a village to raise a child. This image represents the ecological system theory, which highlights the impact of the social environment on human development. So when I was a child fellow, they showed this beautiful image, and you guys get it. It takes a village, and it's all these systems that interplay for a kid's development. Sometimes the kid needs outweigh the system. Sometimes the system's not strong enough to support the kid's needs. But when I saw this image, I said, I wonder what a Black child a community looks like. And I said, maybe I'll make some of that spikes, maybe one of those triangles, because it's an imperfect shape. Maybe some circles are missing. So it's my job to figure out how can we work together to fill in some of these circles, get the right shapes. But I think for a lot of Black children, it doesn't look like this. And that's the challenge. So I did like this image because it made me think about systems practice, but it also made me think about what's missing in many of our Black children's lives. So let's talk about my stomping ground, Marlboro Hospital. Please come visit. We like y'all. So I am trying some things, and I would love your input on this. So this is data. We have kids boarding in the ED for a long time. We're about, I think, 24 hours is probably our average, but we have kids for a few days and some for weeks. And that boarding time has escalated over the years, like many of our UMass institutions. So remember I mentioned going and talking to the kids when I'm walking through. I said, why don't we offer some sort of therapy? And then I changed the safety planning in a group. So when I have 2, 3 teens that have a similar life story, similar struggle, can I get them together and talk to them together as a group? Can I start that safety plan in that way? That way my time is used more efficient. I can get and know the kids together, and maybe we can move them out from their suicidal crisis a bit faster. It's a benefit to doing these groups. We all struggle with doing the documentation that our job requires. So recording safety planning, the EPIC, having paperwork for discharge, et cetera. But if you do it in those groups, you can get more, providers will be more likely to do it. We have more completed suicide safety plans. And of course, I would know if it's working if we have decreased boarding times and increased pre-presentations. So I'm not going to get too deep in this, but I'll explain where I'm at. As I stated, we're trying to train some providers in a good evidence-based safety plan intervention. It's called the Stanley and Brown Safety Plan and Intervention, or SPI. Once they're trained in this and they can watch a video and look at some literature or do formal training in person, I have given them the right to do group safety planning for teens that are boarding, for more than 24 hours. And these group sessions can be an hour long, sometimes shorter or longer. But I like the SPI because it really counts on a clinician and patient working together to come up with a safety plan. And my goal is obviously to improve some of our metrics in this way, so reduce boarding times and actually get more completed safety plans documented. And I want to make sure it's right for our providers. Is this really working? But this project is part of this greater question. How do I reach kids? With little me, how do I reach more kids? I do have hopes and dreams. So my goal is to do virtual groups. So to do the safety planning group with kids at university, with kids all across the UMass system. But first, we got to get it right at our own hospital. And again, this project stems from my concerns about our wonderful children dying. So I said a lot, but what I want you to remember that there is an increase in suicide ideation in Black youth, and there's also an increase in completion, so passing of Black youth by suicide. There are risk factors, but there are also protective factors. Ideally, we should offer interventions that are culturally sound for these children. We got to think about creating a system around these kids to help them belong, and that might be being a little bit more innovative than we're used to being. And I will always point out diagnostic accuracy is very important for this very real reason. We do have kids being diagnosed with ADHD, but we're missing these mood symptoms. So thank you for listening to my presentation. Of course, I want to give special thanks to some of my mentors, Dr. Larkin and of course, Dr. Youngers. And I want to do a special thanks for the Grand Rounds Committee for, of course, my wonderful colleagues at Marlborough Hospital and the rest of the psychiatry department. Any questions?
Well, thank you very much. We have a lot of questions on Zoom, but I didn't know if anybody in the room had a question. Hold on. They complain when they can't hear.
I saw you mention schools earlier on as a place that we may be able to identify people earlier, particularly with things like ADHD, and maybe we're missing some of the internalizing symptoms. Are there other things, like I'm thinking about student support networks that we have in higher education, but are there other things that we can think about implementing maybe at the elementary school level that might help address both the cultural kind of lack of access and also the family being supportive of getting mental health treatment really from a really young age?
Yeah, I definitely think so. I definitely think it's from everywhere. So the biggest struggle, right, is that where's the time? Where's the time that we can connect, like, with our high schoolers, our middle schoolers, and our elementary school personnel? When I was in training, we did visit the elementary schools, talk to the guidance counselors, et cetera. But when you talk to most of the partners, it's a small group of child psychiatrists and a small group of clinicians that take care of kids in general. So what I'm seeing is not so much there's plenty of wiggle room there. And even when you think about religious groups, there are plenty of room there. But what I'm seeing or learning is that we're pretty stretched thin. And so there's tons of opportunity. Everyone's interested in mental health. The children are interested in mental health. But it's us who are so busy, which makes sense to me, that we can't get out together.
Thank you. I'm thinking about data that I've read about perceived discrimination and microaggressions and the effect it has in kids staying in school. And I'm thinking back to your slide about the belonging and sense of worthlessness. So I'm even thinking, is that something that could be incorporated into the education that we provide teachers, and asking that question of how they've been exposed or how they have been perceiving discrimination or feeling the unequal treatment, more than the overt racism, which people may be. It's similar to the dilemma of internalizing versus externalizing behaviors. When it's overt racism, it's easy to see, but if it's more of the perception of the child, how to make sure that we're addressing that as well.
I definitely agree. So in my mind, we give Vanderbilts to teachers, and with the Vanderbilt, I would love to have a separate set of questions just to deal with that, to see what a kid thinks. So I was alluding to it, but to have struggles in school, related to ADHD or anything else, you do, at least in my mind, feel isolated, feel angry, and you got to recognize that there may be genuine anger towards you, microaggressions as well. And the kid may not have the right words to express that. I always say kids are communicating all the time, but they don't talk all the time. And so I do wonder, like I said again, what does suicide look like for these kids? I still struggle. Like I don't think it's a perfect picture, but I do think we should do a better job of describing it. And more research needs to be done. Just the same with bipolar disorder. What does mania look like? And patients of African descent, because the same kind of issues happen where we're missing stuff. Like I do, of course, there is clinician bias, but I wonder if that goes a little bit deeper because we're not really having a verbiage to understand. Like, so I talk all the time about violence, anger, irritability. Could that be depression? Are we really thinking about it in that way? And I always say, I don't know. So again, this opens up deeper questions to me. Looking in this day, that's why I'm so glad to talk about this topic. I said I was joking with my colleague. I said, I wanted to play a cheat code and just talk about art, but this is near and dear to my heart. And I think it needs to be thought about more.
Okay, we'll take some questions from the Zoom world. I would be curious to know if there's any data regarding differences in social media trends in Black youth, like algorithmic biases that increase the risk of suicide and likeliness to express or not express these thoughts. Do you know if there's any data on this?
I don't. To be honest, I'm more curious about that as a research question of my own. I don't, but I'm curious. Again, some of this data brings questions upon questions, and I don't think enough research is being done on it. So I don't know.
Another question, how do you think that systemic racism in policing is contributing? Since law enforcement is often involved in emergency psychiatric care, is there evidence that this discourages treatment utilization during crises?
So I haven't seen a direct study that looked at the numbers for that. I mean, of course, you can assume that. And I think when we're talking, I don't know if we're talking about younger kids or maybe with older kids, I assume you would see more resistance in receiving care, but I haven't looked at a study which shows that direct data.
Another question, how much of a role do you feel intergenerational trauma and transmission via epigenetics/biological memory play in mental health outcome disparities?
That's a heavy question. What stuff I do now. Intergenerational trauma, sharing the same trauma stories, talking about trauma, being a part of that does play a huge role. That's kind of what I went back to that slide about community and environment. There you go. Yeah, that's, there's plenty of data on that, but in terms of the epigenetics, I can't speak to that.
Yeah, it's an interesting question. There in other trauma situations, epigenetics there seems to be something there, but
right. So always does, but I'm not up to date on the data.
Yeah. All right, another question. Lack of minority representation in medicine combined with historical mistreatment by the medical community contributes to mistrust in the medical system and poor health outcome for minority patients. Aside from systemic changes, do you have any advice for providers who are not? Scroll down is the one question. you have any advice for providers? Say, aside from the systemic changes, do you have any advice for providers who are not from racially marginalized backgrounds to improve trust and build relationships with Black and minority youth?
What a beautiful question. I'm going a whole hour for that. I'm not. So that's why it's candle in the dark. I don't think you have to be a minority to offer hope to someone. These emotions you're feeling are universal. And again, I gave a story where I was not adopted, and I am not a 17-year-old girl, and I'm not from Marlboro. I don't know the specifics of this person's culture, but here's the key thing. They're not silly. Be curious. Want to know them. They will trust you. That's just natural human. That's the way humans function. So I get plenty of stories about, how I ended up at Mayo Clinic in Rochester, very cold there. But I was asked the awkward question, and I'll share just a brief story. So I am a Black man, and I was in the middle of Rochester, December 6th. It was extremely cold. I think it was -20. It was really cold. And I was on an interview trail, but very quickly, had a great interview, but I was like, I don't know if I'm gonna come here. And I had a white gentleman, great guy, we still talk to this day. We shared kind of pleasantries in the interview, and he was like, Suliman is my first name. Do you have any more questions? I was like, no, it's a great interview. So I got a question for you. Where are you gonna get your hair cut? And this is a white man telling an African American. We laughed for a little bit, and then he gave me places to get my hair cut. And that made me say, hey, they are aware that I'm a bit different in this community. As a psychiatrist, me walking around, they're gonna know who I am. Like, this is a small community, so if I get someone committed, they're gonna know it was this guy. And so we are here to protect you. You do belong in this community. So that sense of belonging you have to push. And the way it works, and I kind of pointed to this data here, is trust. So most of the times, as we all do, we trust our friends and family. So we trust a good referral from a friend or family. So once you bring in one person, you tend to bring in a bunch other, because they say, this is a safe place. They will protect you here. It's not like other places. This is a safe place to rest. And so that's, you don't necessarily have to be a Black person to do that.
Well, we don't have any more questions other than you've gotten a lot of thumbs ups and hearts on the Zoom. So I think people really appreciated your talk. Thank you very much.